Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today in my lesson, I'm going to touch briefly on Parkinson disease. Salient features of the etiology, clinical presentation, and pathophysiology of Parkinson disease, adding a note on the current modalities of treatment are the objectives of this particular lecture. Parkinson is a common neurodegenerative disorder affecting elderly characterized by slowness of movement. In addition to the slowness of movement, there should be two of these symptoms, that is, tremor and rigidity, as the feature of the symptomatology of Parkinson disease. There may be other symptoms like loss of smell, excessive salivation, mood changes, constipation, soft voice, and sleep dysfunction. Sometimes excessive periodic limb movements during sleep. Some of the patients, they do experience this particular symptom. It affects nearly 1% of the population after 60 years of age. It is said to be due to the loss of dopaminergic neurons in substantia nigra and presence of Lewy bodies is the characteristic histological features in nerve cells of the basal ganglia and the areas that are affected. In most of the patients, cause is not known, so it is said to be idiopathic. Okay, genetic factors play a role in few of the patients, more so in the patients of younger age group. This disease has a gradual onset involving tremor on one side of the body, okay, that slowly progresses to develop rigidity and slowness of movement. As the disease progresses, there could be autonomic dysfunction and postural disturbances in course of time. Well, this is one of the most important disease, that is Parkinson disease, which is diagnosed mainly based on history and clinical features. Okay, diagnostic workup give a little information for the diagnosis of this particular disease. SPECT scan is done in doubtful cases. Okay, coming to the etiology, this area has been touched for a long time. There has been immense evolution in understanding the etiology of Parkinson disease over a century since the time the disease was discovered by James Parkinson in 1919. In 1919, they found the loss of pigment in substantia nigra. Okay, they said this could be the cause for Parkinson disease. Subsequently, in 1950, loss of dopamine in subcortical motor circuitry found to be the cause of Parkinson disease. Okay. It is said this is the disease of basal ganglia, which has excitatory and inhibitory circuits from motor cortex. That is, basal ganglia are the nuclei that are located in the subcortical region. Corpus striatum, globus pallidus, subthalamic nucleus, and substantia nigra constitute the basal ganglia located in the subcortical area. They have got the inhibitory and excitatory circuitry from the cerebral cortex, from the cerebral cortex down to the basal ganglia. Basal ganglia, in turn, they have got the nerve tracts influencing the lower center, that is spinal cord. Okay. Ultimately, they influence the voluntary motor action. There is deficiency of the dopaminergic neurons and accumulation of alpha-synuclein in the Lewy bodies that appears to be the cause for this particular disease. That is an abnormal protein, that is alpha-synuclein, getting accumulated in the neurons, leading to the degeneration, thereby causing the deficiency of the dopamine levels in these circuits. Genetic factors play an important role affecting the younger individuals. Okay, if there is a patient in the family with Parkinson disease. Coming to the epidemiology, more common in men than in women. It is said 1 to 2 persons per thousand in one's lifetime. It occurs involving the 1% of the population of over 60 years. And there is genetic predilection in 5 to 10% of the population, 10% of the patients. They give the history of genetic factor. It has been found that prevalence increases with increasing age. Okay. Coming to the pathophysiology, what is happening in the various tissues that are presenting with the symptomatology? There has been great research in different races about this particular disease, and genetic factor as an autosomal dominant gene has been observed. So then a circulation of the dominant gene in certain of the races in the world, confirming the genetic factors in the form of the autosomal dominant gene as the cause for this particular disorder. There is a deposition of alpha-synuclein in the neurons of the substantia nigra, subsequently resulting in neuronal degeneration, thereby depleting the dopaminergic neurons. There have been increasing reports on accumulation of this alpha-synuclein in meandric plexus of the gastrointestinal tract. Okay. From there, it progresses to dorsal motor nucleus of the vagus, certain of the nuclei in the pons, that is especially sleep centers, and also nuclei of the midbrain. So leading on to degeneration of these nerve cells following accumulation of this particular protein. So PD is not merely due to deficiency of dopamine, it is something else. That is, alpha-synuclein protein is the area of current research. The histology. If you consider any degenerative disease, there is neuronal loss. Okay, there is progressive degeneration of the nerve cells, resulting in the presentation of the different clinical symptoms. So, any neurological disorder has a insidious onset with relentless progression due to the degeneration of the nerve cells. So is the Parkinson disease. Okay, the degeneration sets in the nerve cells of the substantia nigra in particular. This is the pathophysiology that has been accepted in Parkinson disease over a century. At present, there have been reports, there have been studies and the reports in the current literature. The degeneration begins in the dorsal nucleus of the vagus in medulla due to transmission of some unknown toxin from gut as retrograde movement to dorsal nucleus of the olfactory bulb nucleus ceruleus in pons, and then to the nerve cells in the pars compacta of the substantia nigra. This is said to be the synuclein, alpha synuclein pathway. Okay. As the disease progresses, structures of the basal forebrain and amygdala are affected. This is how the progression of the disease occurs, involving the degeneration of the various nerve cells at various locations. Finally, the disease involves autonomic nervous system also. So, Parkinson is a multi-system disorder not simply related to substantia nigra dysfunction. This is the current research reports with regard to progression of the Parkinson disease. Coming to the clinical presentation. Number one is the first symptom is tremor. This is the earliest symptom of Parkinson disease, which is usually unilateral, occurs at rest, okay, disappears for a few minutes when the hand is put to action. That means when you ask the patient to pick up a book, for example, he picks up the book, the tremor disappears. Okay. Once he keeps the book away, leaves the book, and keeps the hand at rest, the tremor reappears. This is the characteristic feature of Parkinson disease. But as such, based on tremor, you cannot make a diagnosis of Parkinson disease. So there should be other symptom complex like bradykinesia. Bradykinesia is the second symptom. Symptom number 2 is common in Parkinson disease. Okay. Patient says he takes longer time to complete a task. He's very slow in completing a task that is given to him. Then in the clinic, when he is asked to tap index and thumb finger rapidly in succession, he cannot do it that fast as it is normally done by the people. At the same time, when he is asked to stamp the foot onto the floor rhythmically and rapidly, he cannot do it so. Then third symptom is rigidity. When you look at the patient appears stiff. He feels difficulty to get from chair without support. Okay. And you can also see the stiffness in the hand as the arm swing is slow on the affected side. When you examine the patient for passive movement around a joint, there is hypertonicity, okay, which is lead pipe type. How do you look for the tone of the muscle? Make a rapid passive movement across a joint. Look for the resistance offered for the movement. So increased resistance for passive movement around a joint is hypertonicity. It is lead pipe type. What is the lead pipe type? Uninterrupted, persistent hypertonicity of the muscle, okay, in the form of increased resistance for passive movement. This is the feature of rigidity in Parkinson disease. Then the fourth symptom is gait disturbance. Gait disturbance is rather late presentation. Patient makes slow and short steps. He will have shuffling gait. At times, his gait is fascinating type. He stoops forward in order to maintain the balance, in order to avoid the fall. When he suddenly come across a difficult situation to pass through, like when he faces or comes close to a door frame, he freezes. Then other symptoms being constipation, soft voice, salivation, swallowing difficulty, at times he chokes, postural hypotension. When he gets up from the lying down posture, he feels giddy. There is progressive memory loss and cognitive deficiency. The patients may suffer from depression and anxiety. As the disease progresses, there could be autonomic dysfunction. Symptoms of autonomic dysfunction being constipation, urinary retention, and erectile dysfunction. Symptoms of autonomic dysfunction, they do not respond to treatment. Coming to the evaluation. History and clinical examination are sufficient to diagnose Parkinson disease. Right? Laboratory workup help you very little in making the diagnosis of Parkinson disease. You can do MRI imaging in order to eliminate other conditions like normal pressure hydrocephalus and subcortical silent infarcts. Because normal pressure hydrocephalus also occurs in elderly people, that also presents with the gait disturbances, okay, cognitive deficiency, and urinary incontinence. This condition has to be excluded to confirm the diagnosis of Parkinson disease. That is the reason why we go for MRI. And response to the levodopa is diagnostic. If you give the levodopa in low dose, the response to levodopa indicates Parkinson's disease. But it is only temporary. Okay. You can go for DAT scan to test dopaminergic uptake. This is not routinely done. When the diagnosis is definite on the basis of history and clinical findings, most of the experienced neurophysicians, they go by history and clinical examination and put the patient on treatment. Very rarely DAT scan is done in some of the selected patients to confirm the disease. Coming to the treatment, there is medical therapy, physiotherapy, surgical therapy, and recent modalities like IVIG in certain papers that has been described to show some benefit, and stem cell treatment. Medical therapy includes levodopa and other dopaminergics. Response is good for 3 to 6 years, followed by resistance and rapid deterioration. The disadvantage of these dopaminergics is they have on and off motor effects. Okay? And side effects are plenty. Over time, patient will develop tolerance. That means efficiency of these drugs, it will come down, and patient will have the onset of symptoms. It is the dictum to treat the young patients aggressively. That's important. Then other modalities of treatment being physiotherapy. Put the patient on programmed exercises, and it has been said music therapy is going to show good results. The patient with the Parkinson disease, he may not be able to walk properly. He will have the bradykinesia, tremor, etc. We find that particular individual dancing very well when put to music. And cycling is one of the good exercise showing beneficial effect in the improvement of tremor in the patients with Parkinson's. Then surgery, deep brain stimulation and insertion of the pacemakers in defined I mean locations are going to show the good effects in certain of the patients. Patients who are not responding to medical therapy and other modalities of treatment, they are put to deep brain stimulation with good response. And this procedure has been accepted increasingly in the current treatment modalities worldwide. Coming to a brief note on prognosis. Patients presenting with gait disturbance, postural abnormalities have poor prognosis. It is here the postural abnormalities. They have poor prognosis. If the initial presentation is disturbance in the gait and difficulty to maintain the stance or posture, these patients they progress rapidly, having poor prognosis. And older patients with cognitive deficiency who do not respond to medication, they do have poor prognosis. Patients who present with tremor as initial complaint, they have long benign course. This is a good observation. Older patients presenting with hypokinesia or rigidity also progress rapidly, ending in death. And well, we look at some of the pictures of the Parkinson disease. This is the picture showing Parkinson's signs and symptoms, which may include tremor, slowed movement, that is bradykinesia, rigid muscles, impaired posture and balance, loss of autonomic movements, loss of automatic movements, speech changes, and writing changes. These are the certain of the symptoms and signs in the patient with Parkinson. That is, to repeat, tremor, bradykinesia, rigidity, impaired posture and balance, loss of automatic movements, speech changes, and writing changes. When you ask the patient to write a sentence, the size of the letters they slowly become smaller and smaller. This picture shows the structure of the brain, showing the basal ganglia, that is substantia nigra, thalamus, and the corpus iodum, that is cardiac nucleus, and the putamen, and their circuitry with the other centers of the brain. This picture shows this is the area for the black dark area is this substantia nigra showing pigmentation. This helps to for it will tune the movements and this is a deficiency of the substantia nigra dopaminergic nerve cells results in resting tremor. Okay, so this is the basic pathology that has been described. Deficiency of the dopaminergic nerves in the nerve cells in the substantia nigra has been the concept for a long time, that resulting in Parkinson disease. This individual shows again the patient with Parkinson disease. So it's showing, see, stooped posture, masked face with no expression, back rigidity, forward tilt of the trunk. You see the reduced arm swing, reduced arm swing, and hand tremor, slightly flexed hip and knees, tremor of the legs, okay, flexed elbow and wrist, and there is back rigidity. So these are the, if you look at the patient with Parkinson disease, you can observe all these findings. So it is very easy to make a diagnosis based upon the clinical signs and symptomatology. This is again the circuitry and of the basal ganglia and other structures involved in the Parkinson disease. Well, this is again the picture showing the patient with Parkinson disease, and you see these are the area of substance nigra which has lost its pigmentation. So there is a deficiency of the dopaminergic neurons resulting in Parkinson disease. So we'll treat the patient with the dopaminergic drugs in order to improve the symptomatology. Well, thank you very much for patient listening. If you like my video, please subscribe to my channel. We'll meet you again in next class. Until that time, thank you and bye bye.